I'm an associate professor in the Department of Family Medicine. I see patients. I'm also medical director at the Ypsilanti Health Center, which is a lower income community clinic that is run by the university. And I am also a health services researcher. I do research mostly on physical activity to prevent and treat chronic diseases, and also on diabetes prevention. As an undergraduate, I was at MIT and I studied mathematics and computer science. And then I went to Harvard Medical School. In the middle between that, I actually did some work in the Peace Corps in Africa for 2 years. And the combination of the three experiences, I think, led me to be a researcher in health services with a lot of quantitative methods focus. The big picture hope is that we can somehow reduce the prevalence of diabetes, type 2 diabetes, which is a obesity-related, diet and exercise-related illness that is draining resources from our healthcare system and our economy. It's a little bit unclear at this point whether the interventions that we're using to prevent diabetes are cost-saving or just cost-effective. Cost-saving is sort of the holy grail of health services research, something that actually saves us money and creates better health outcomes. That's a rare thing. But if we do it right, I think there is the potential for diabetes prevention to be one of those cost-saving, no-brainer, let's do it for everyone kind of thing, because it saves everybody money, leaves resources for whatever we choose to use them for. We're in the middle of a pretty major healthcare transformation with the Affordable Care Act. More focus on value, more focus on finding ways to deliver healthcare more efficiently and effectively with a patient-centered focus. In academic medical centers, that has really not been the focus in the past, and it's having to shift and find ways to do more efficient, more value-based care. Prevention has taken a pretty major role in value-based care because obviously if we could prevent people from getting diabetes, we wouldn't have to pay to treat their diabetes. But there's a very complex economic picture around prevention. How many people do you have to treat to prevent one case? How much does it cost over how many years? Who pays the bill and who gets the benefit? All of those complex interactions are changing and shifting in a very dynamic way right now because of healthcare reform. And I don't think anyone really knows where it's going to end up. It's very exciting to be part of IHPI, where other people who think about health services research from the big picture, from the policy perspective, from the economic and cost perspective, from the broad scale reach and dissemination perspective, can talk to each other and share ideas. So IHPI is a great home for the kind of research that I do. When we moved over here from the VA hospital where our old CCMR site was, I underestimated the impact that it would have on us. And I was sort of stunned by the impact of walking down the halls and seeing all of these other people who were doing the kinds of research I was doing in different settings or with different methods or different targets and different departments. Being able to meet and collaborate with them was really powerful. I certainly would hope that we would have more efficient, more patient-centered care in the future, that we would put more emphasis on prevention and less emphasis on acute care, and that we would be more able to tailor our interventions to individual patients' needs and resources. Finding a way to deliver efficient care but still to respect the differences that people might have is difficult. That's really the challenge that all of us are dealing with in one aspect of that or the other.